So the next talk is by Dr. Anurag Mishra. He's going to talk again on greater degree of spectacle independence for intermediate tasks.
Thank you, sir. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. I'll just expand on what Mahipal sir has already said, and since we discuss a lot and we hear a lot about different IOLs, the design perspectives, the material perspectives, let's put all that debate into place, let's put all that debate into rest and discuss on which IOL would I like to have in my eyes. Should I have a cataract, right? So that should put an end to the discussions that we've been having for such a long time. Here is me. I'm a 50 years old male, or a little more than that. I do have cataract, one or both, doesn't matter. And I have reduced visual acuity for which I need to undergo surgery. That's not all. I have a few requirements. I have a pre-existing compound myopic astigmatism. Compound myopic astigmatism, which is very minimal. I do need to write prescriptions on the screen. I use an EMR to see my patients and write down the findings on the screen. I operate through the microscope light, and every surgical microscope that throws a large amount of coaxial light, some amount of that actually reflects back to the surgeon's eye. So I do not want any glare to happen from the patient's eyes, reflections through the microscope eyepiece again. I am a marathon cyclist. I do bike under the stars. We do take up a lot of cyclothon expeditions under the stars, 200, 250 kilometers running over the night. I love driving. I do love driving my car. I do not even have a driver hired for me, so I always drive myself. And I've subscribed to most of the journals, so I don't have to read a lot of black letter signs, so I don't read much of texts. I do read them from the screen. So to compensate all that, my requirements are, I require a crystal clear, undeterred distal visual acuity. I do require lower order aberrations to be neutralized because the quality would then be enhanced. The higher order aberrations to be brought down as minimal as possible. See how the higher order aberrations are doing in my eyes. I need a largely unaided intermediate visual acuity and no glare and distortion. Near comes secondary. These are my requirements. And when it comes to the tris and the EDOFs and we talk about neural adaptation, I'm a busy practitioner, supposed to be. So I cannot afford any time to be given for this so-called neural adaptation to take place. I want my vision bang on the very first post-op day. I can't afford time for that. So let's get on to my measurements. These are my measurements. Nothing much to speak about this, but there's one thing that catches your attention. This is my photopic pupil size, which is 4.2 millimeters. 4.2 millimeters photopic pupil size. Herein, everything's doing fine. The higher order aberrations are onto 0.8. That's okay. The coma and trefoil are fine. They're doing fine. The angle alpha is 0.625. Now, when you choose a particular trifocal and the angle alpha is a particular number, we know that we divide the diameter of that central bullseye, and the angle alpha has to be within that. And I'm a very, very strong believer of the angles playing a role in the adaptability of trifocal IOLs. I do not believe that they don't have a role. They do have a role, because I've seen people burning their fingers in that. So with these measurements, the angle alpha being a little on the higher side, and my photopic pupil being at 4.2, what should I choose? I should choose a trifocal. Should I choose a trifocal that has a diffractive zone more than 4 millimeters, so that it aids me in reading in photopic conditions? And the central bullseye has to be around 1.2 millimeters because the angle alpha is 0.6. Fine, we do have a product in the market which has both of these. But my measurements are not finished. There's still to come. These are my MTF curves. The cornea is doing fine. The internal MTF is, of course, distorted because I do have a cataract. But what's even more is, And what's even more is, the higher order aberrations are also doing fine. What's even more is the angle kappa is 0.533. So that makes me essentially unsuitable for any trifocal. Any patient who has an angle kappa of more than 0.3, I declare him unsuitable for trifocal IOLs, because my observation has been very contrary to what the industry, what anybody else could believe. So trifocals, as I found out, are a no for me. The next thing that comes in is the EDOF. The EDOF should be the right choice. Again, reminding you that the angle alpha in my case was 0.6, which essentially makes me unsuitable to receive an EDOF, just as this patient. This is a post-operative DLI curve of a patient who had received an EDOF, and look at his angle alpha, it was 0.6 or more than that. Look at the DLI score, 2.05. When this patient came to me extremely dissatisfied with the initial eye surgery, what I did for the other eye was implant another lens, with which the patient got bang-on DLI of 10 score, of a score of 10 on the internal plane. Which IOL did I put in the other eye? Was the Vivinex Impress. So this is what I taken. Even if this is a solitary anecdotal observation in one patient, I would still stay away from the EDOFs. I do not believe that they are completely angle alpha dependent. So the message I have for myself is, if it's a tri, the kappa is to be looked at. If it's an EDOF, the alpha is something I very strictly look at. This is one patient wherein in the left eye, some other enhanced monofocal was put. And in the other eye, in the right eye, I had put in a Vivinex Impress. This is just one of those patients wherein I have done a match. So the depth of focus, since this is a FS-OTF curve, this takes into account both MTF and point spread function, and since they are counter-regulatory to one another. In the right eye, which has the Impress, the depth of focus is slightly less. It's 0.7, as the curve shows. It's slightly more in the other IOL, in the other eye. But if you look at this peak of that graph, it crosses 0.9, the 100% curve. The graph is very steep, so that determines the quality of vision that the patient receives. So what it slightly loses maybe on the count of DOF, it compromises more than compensates for in the terms of quality of vision. So when we subject this patient to this DLI again, this is the right eye, which has, the patient's not complaining exactly, but still the DLI score is 9.01. With the Impress eye, it is again stationed at 10. So these are the things that I take into account when I see my patients, with the observations that happen, and the measurements that I have in my eye. I would certainly bang on choose the Vivinex Impress, and I completely agree with my Palsar on that. This is actually a universal eye. Don't look at anything. If you're not sure about anything, go ahead and put it in. Now, this was one patient who had come to me demanding for a try. I had selected him for a try too. I'm not saying that I have this sort of a cataract, but this sort of a cataract can also come to you demanding for a spectacle-free vision at all distances. What happened in here is, since the cataract was a lot intumescent and plenty of fluid-filled pockets were there in the mid-periphery, the moment I tried to do a rhexis, it started going out, and the moment I was trying to push in some viscoelastic, it stepped off, and one side of the Argentinian flag happened. As I was trying to retrieve and salvage the capsule, the other side also opened up, making it a complete Argentinian flag. So whatever I had left with me, I tried to manage with that, very minimal rotation, trying to make a rhexis out of it. Following was a slow motion phaco, downing your parameters. Fluidics are always low in my surgeries, whatever. So luckily the cataract was not very hard, all the while looking at the flaps, how they're fluttering, is the flap motility sign positive or negative. Now after I have a bag, I still have enough support for this single piece IOL to go in. So I put in the Vivinex Impress in this case. So what I mean to impress here is, by the Impress is, come whatever the situation may be, whatever compromising situation it might be, and then I just expand the rhexis because I thought the opening was too small under cover of BSS on both sides. So this patient did very well post-operatively. In fact, I couldn't give him a complete spectacle independence as I had promised him initially, but what I gave him was was more than he could have wished for. I mean, I could have wished for after landing up in that kind of a compromised situation on the table. So talking about experience, we are not as massive as Mahipal sir is, but still around 90 to 100 implants thus far. And I completely agree with him when he says that we do get a defocus of around 1 to 1.25 at 50. And they all achieve, virtually all of them achieve, barring very few exceptions, an N6 after particularly bilateral implantation. After bilateral implantation with the +1 at 30. So the quality of vision is supreme, and intermediate vision is very good, hardly require any assistance of glasses for intermediate, and for near they need a minimal add of around +1. Max can go up to 1.25. So after bilateral implant, if say the phone is kept on the desk or even on the kitchen platform while the lady is cooking, the call from the number from where the call's coming, the incoming call is coming, is clearly visible on the screen without the assistance of glasses. They can also do their household work, majority of them without the assistance of glasses. For very fine prints, of course, they do need, but it's again around 1 to 1.25, as I mentioned. That's all I had in this edition. Thank you so much for the attention.
Nice presentation, Anurag. Just one quick question. Have you ever had occasion to, or will you ever mix and match, say, an Impress with a Geometric Plus or a Geometric? What situation would you consider that?
Basically, I actually do not mix and match two different concepts. That's not my way of doing things. If I have a situation wherein in one eye it's perfectly suited for a geometric, and in the other eye it is absolutely unsuitable, and the patient does want near vision without glasses, I might just think about, I've never done it, but I might just think about it. But what I've seen in other mix and matches from other manufacturers or other products is that even if it comes with the same material platform, if the concepts are different, the output is a little different on the quality front. So they don't have the same kind of experience with the two eyes. When they compare, they do find differences. So I generally avoid that. But if this is the situation, and after explaining everything to the patient says yes and accepts it, then I might.
Great.